Good morning and welcome to our latest Posturite webinar on a beautiful, slightly spring, though dare I say it, morning. I'm delighted to say that we have Dr. Adrian Massey with us this morning to talk about health and safety, mind the gap. But before I move on to Adrian and his talk, I just want to run through a few bits of housekeeping. As you know, we do record all our webinars, and so if you have any technical issues, be assured that the webinar will be available to you later. So please don't worry, and you'll be able to listen to it again and share it with your colleagues as well. You may also have some questions, and if you have any questions that you wish for me to put to Adrian at the end of this session, there is a questions box in the right-hand side of your panel. Please type in your question and submit, and I will get through as many of those as I can at the end of Adrian's talk. So really, I just want to hand over now to Adrian. Just to let you know that Adrian actually is an accredited specialist in occupational medicine, and he's a fellow in the Faculty of Occupational Medicine and sits on the Executive Society of Occupational Medicine. He's been a director of the UK's largest outsourced occupational health services and has been, for Duradiamond, and he has recently become their Deputy Chief Medical Officer. He's involved in developing class-leading case management services for employers, so he's well placed to talk to us on this subject today. He's worked in a wide range of for employers, including police force, government agencies, retailers, telecommunications, so a wide scope. So I really want to hand over to Adrian now, and he's going to be talking really about where occupational health is it stale, is it still fit for purpose, and where perhaps we might go from here. So Adrian, over to you.
Thank you, Catherine, and hello to everybody on a Friday afternoon. I just put up thank you for the introduction, Catherine, so I won't revisit that. And the first slide to look at today is a bit of an overview of what we'll be going through over the next 20 minutes. Really, my key theme here is that I think occupational health has maybe become a little bit stale as the years and indeed the decades have passed. I'm not sure to what extent service provision actually does improve year by year and over time, or how well we're really satisfying client expectations and the expectations of UK PLC for what occupational health can do. And so I think part of the root cause for that is that we have become fairly stuck in quite a constrained way of thinking with this phrase of health and safety, which we routinely use almost automatically when we're talking about interactions between health and work, but which actually may be something of an impediment for us in terms of thinking slightly differently and in a slightly more sophisticated way about health problems, which in turn might help us to design much better services which are much more effective for the needs of employees and employers. So what I'll do is we'll look a little bit at health and safety, what it actually means, what the good points have been, because there have definitely been advantages to this approach, but also where the gap really lies and what we're missing, which leads on to some interesting areas of how services could be made much better in the future. And because of time constraints, that's really the theme I'm going to focus on. At the end, I will talk in summary about what I think that means for provision of occupational health services, but of course, in questions after, it may well be that some of the detail of that is of interest. So, first of all, what do we mean when we talk about health and safety? Well, it's really this combined approach of prevention on the one hand, which is more of the safety angle, and then a reactive component for people who've actually developed health problems. So if we can identify ways in which people can obviously be injured or made ill by their work, so that might be falls from heights or electrocution, poisoning, that kind of thing. Once we've identified a clear cause and effect, then by putting in place control measures, by changing the ways that people work, we can prevent those problems developing in the first place, which is obviously the ideal approach. But life being life and things not being perfect, there will always be some element of injury and illness, and of course there'll be some element of that just not related to work, but in the employee population as a whole. And there, the health component really comes in, and what we hope is that through diagnosis, through identification and assessment of the problem, and then through medical treatment, that we're able to make things better and restore that person's capability for work. So when we talk about the health and safety paradigm, that's really the sort of the twin approach which is embodied by that. And there's a lot to be said for it. The safety approach in particular has made very impressive inroads into workplace injuries over the years. So Health and Safety Executive were keen to promote on the 40th anniversary of the Health and Safety at Work Act, so that came in 1974, had its 40th anniversary in 2014, that in the intervening period, raising awareness of workplace risk, improving legislation, improving compulsion and regulation, had resulted in an 85% reduction in workplace fatalities, which is really very impressive. You know, we wouldn't expect to see improvements of that magnitude through health interventions, for example, or we'd be very pleased if we did. So that graph at the bottom there is really showing that how impressive the decline in the rate of workplace fatality has been over recent years, more than halving really over the last 20 years or so. So the safety approach certainly has a lot to be said for it. But it also has its limitations as well, and part of the problem with the safety approach is it can be positively counterproductive when it's taken out of its proper context. So by that I mean when that mindset, when that approach of regulation and enforcement and awareness is applied to problems which either really aren't that serious or where there isn't such a clear cause and effect relationship. So if we were to look at death from electrocution or serious injuries caused by falling from heights, the cause and effect relationship between those two is very clear, and equally the magnitude of the effect is very great. But when you misapply that model to health conditions that don't satisfy that criteria, problems can ensue. And this graph at the bottom is an interesting one. It's been composed from data provided by DWP by a colleague of mine, Mike O'Donnell. And what it does is it charts for days lost to back pain in the United Kingdom, really from the early 1950s and right up to millennium. And what's interesting is there was a progressive, and indeed in the 1980s and 90s, exponential increase in days lost to back pain, which really makes very little sense. It flies in the face of all intuition, because of course this was a period where mechanisation and automation had come in, many job roles have become significantly lighter, the number of people employed in traditional heavy industries was decimated during this period, and of course, as the graph shows, there were plenty of points along the way where statute and regulation and enforcement had been applied in the hope of improving the problem. And in fact, it had, on the face of it, quite the opposite effect. And of course, we see very similar phenomena with other common workplace health problems, in particular upper limb disorders, and there's a much documented RSI epidemic in Australia in the 80s, which followed a very similar pattern. So I just make the point with this slide that although the safety concept can work very well in high hazard environments, out of high hazard environments and dealing with health effects where there's a much weaker cause and effect relationship, it may not be so advantageous for us. And the same is of course true for health. So modern medicine, the promise of modern medicine, has really been miraculous for many people over recent years. It's something of a surprise that the founding principle of modern medicine, which is that when people have symptoms, there's likely to be an underlying problem for that, which if you can identify it, you can then treat it. That's actually a relatively modern mindset. It's only in the last 200 or 300 years since Thomas Sydenham that medicine has really been premised in that way. And of course, it was a quantum leap in our understanding of disease, because this was the era when people no longer died of coughs or consumption or fever, because there was an assumption that that was inevitable. And of course, we started treating pneumonia and TB and so on. So it really opened a Pandora's box, this recognition that symptoms often represented or could represent the presence of some underlying disease process that we could interfere with. And on this graph, on this slide, you can see pictures there demonstrating improvements in cancer care, in treatment of chronic neurological disease, and of coronary artery bypass grafting. I did find a much more vivid and graphic photograph of coronary artery bypass grafting, which I was tempted to use, but this being Friday lunchtime, I've put a line diagram in instead. And the point really here is much the same as with safety. Unfortunately, the health concept can be stretched to breaking point. And there is definitely a point at which medicalising a problem can have negative counterproductive effects. There are lots of different examples of this. Probably the most prominent one in the press at the moment is the concern about the relentless increase in antidepressant prescriptions, which have gone on over the last few decades, demonstrated in the graph at the bottom. And of course, that has to have detrimental side effects, and they may be very direct in terms of side effects from prescription drugs, for example, but also more subtle and pernicious effects amongst workforces and populations. So, for example, loss of resilience, dependency forming relationships on healthcare professionals, medicalisation of problems to which there may not be any very satisfactory medical answer. And I guess another good example of the problems of over-medicalisation would be the overusage of antibiotic prescriptions in recent years, where again we're beginning to see there can be detrimental effects to that. So this is a really important point really, and the main point I want to make today, which is that yes, safety and yes, health, each of them as approaches, as concepts in their own right, they have use for us and they can deliver improvements in health and in people's productivity, but at the same time, if they're misapplied to problems, they can be counterproductive. And this is a lovely slide on this graph produced by Kim Burton, who's contributed a lot to the government research on health work and wellbeing. And what it's really demonstrating here is summarising a lot of what's just been said. So the yellow line there represents decreasing workplace risk as automation and regulation have improved working conditions for people. The red line represents the improvements in medical technologies that we've seen. Don't worry so much about the green line. That's really just meant to demonstrate that in any population there will be a level of disease at any given point in time. But of course, what's completely paradoxical about this graph is the blue line, which shows levels of disability amongst the population, which increased exponentially during that period that I mentioned into the 80s and 90s. And there are lots of markers of that. You could, for example, look at claimant counts for sickness benefits, which went up many-fold between the 50s and 90s, entirely in the face of what we would expect from having applied this health and safety approach. So something is missing from our thinking. We need a different way of looking at this problem to begin to understand what the solutions might be. And increasingly, I think the area of interest is what we would call common health problems. So this graph is really a snapshot of absence amongst the UK population. It's from 2013. It would be very similar today. And the great majority of absences, probably in the region of 70 to 80%, are not in relation to particularly serious or unusual medical problems. They're in relation to common health problems: backache, neck-ache, mild and low-grade psychological distress, stress-related symptoms, mild anxiety, depression, coughs and colds, all those kinds of things. So that's interesting. About 70 to 80% of the absence that we see in the UK seems to be conditions which in themselves don't automatically fit neatly either into the health box or into the safety box either. So it's worth considering these common health problems a little further. Here's an interesting study. It was undertaken in the 90s by a researcher called Eriksson. A large number of members of the general population in Nordic countries were stopped in the street. These weren't people who presented to their doctor or who'd sought healthcare in any particular way. And they were asked which of a range of symptoms they'd experienced in the preceding 30-day period. And here are the results: a number of symptoms that people were asked about and the prevalence of reporting. And you can see that the prevalence of symptoms in a population that doesn't attend their doctor is really quite high. So around 50% of people have reported symptoms of tiredness, for example, in the preceding 30 days. Worry, depression, headache, musculoskeletal symptoms, all very common. In fact, at least 75% of people could recall having one of the symptoms listed in the preceding 30 days, and more than 50% could recall having at least two. So that's interesting. So although it may sound blindingly obvious, common health problems are indeed common. And interestingly, they also tend not to be serious. So this is the findings of another research group, this time Cronker and Mangelsdorf from the late 80s. They followed up a large outpatient population from a medical clinic. So these were people who had sought healthcare because they had any one of the symptoms listed on the x-axis there. Most of those are self-explanatory. Edema means swelling of a body part. Dyspnea is breathlessness. And what the researchers did was they followed these people up intensively over a 3-year period to see at the end of the day, when they'd been investigated to the nth degree, when they'd had all their investigations and assessments, in what proportion of cases was an underlying problem of any kind identified to account for the symptom. And it's surprisingly low. As you can see, overall, somewhere in the region of 5 to 10% of people who present to a doctor with a problem, with a symptom, I should say, will actually turn out to have any underlying disease process that can be identified and that would account for the symptoms that they've had. So although we automatically assume, because of the power of the medical model, that when people are reporting symptoms, there's likely to be an underlying cause, and if that can't be found, it's probably because the doctor's a bit daft. In fact, that's very mistaken, and the great majority of the time, it's because it's normal human life, and not indicative of any serious underlying disease process. This slide is really quite an important one in what I'm trying to explain today, because I think the mistake that we may have fallen into over the years is, as we've adopted the medical approach to life, we've begun to fall into a trap of thinking that the population of people who are in work, as opposed to the population of people who are out of work, is very substantially different, and that they're really defined by the presence of some serious medical problem. And all the evidence is that that is not true. So on the top left there is another graph produced by Kim Burton, which is a nice way of explaining how there are different degrees of health problems amongst different groups of people. And actually, yes, whilst there are a substantial number of people who won't have symptoms at any given point in time, a very large number of the working population at any given time will have symptoms, and we've seen that from the Nordic study I mentioned a couple of slides ago. Of course, the extent to which those symptoms are actually relevant to work and would actually impact or impair someone from doing their normal job will be lower still. And the extent to which those are symptoms which would be sufficient to stop someone working, lower still, and so on and so on. So what we're really beginning to see is that actually common health problems are ubiquitous, and that the population who are in work and the population who are out of work are really not so different in terms of the nature of the health problems that they face. And that introduces the interesting question of why some people are in work and some people aren't in work. And increasingly, we're beginning to see that the health problem is not a problem in isolation. The best analogy is more of the straw that breaks the camel's back. So people face all kinds of challenges to their coping mechanisms in day-to-day life, depending on what's happening in their personal lives, in their family lives, in their working lives. All kinds of things will impact on how people are feeling and coping at any given point in time. And often at a time when they are really under strain, when there's some challenge to their coping mechanisms, the thing which ostensibly takes them out of work, which is their symptom, their health problem, may really be the final straw. The key point being that to focus too heavily on that final straw, to talk to the person exclusively about their back pain or about their low mood or about whatever symptom it may be, may actually be to ignore the great majority of the problem and inevitably limits the scope for intervention. And for anyone who's interested in reading any more about this different way of thinking about life, Nortin Hadler, who's a fairly esteemed American physician, has written extensively around it. And that book there, The Last Well Person, is a really erudite and very convincing discussion of disease patterns in Western populations. And it really helps to throw some context on that graph I showed earlier, which is that disability levels seem to be increasing in society against all that we would predict from improved medical care and safer jobs. So this is really the gap that I was talking about at the very beginning. And this is a slide which hopefully begins to put it together in a more cohesive way now. So we've already explored the safety agenda and the ways in which that can be helpful to us. But the important caveat is that really is only going to be appropriate in situations of high hazard where there's a very clear cause and effect between what you're trying to prevent and the thing that causes it. And when it's taken out of that scenario, it can cause all kinds of problems, compensation culture, irrational fears about working, and so on. And then to the right, the health agenda, which, as we've said and as we've seen, can be very helpful for people with serious disease, serious illness, but again, which can cause all kinds of unwanted side effects when it's misapplied to problems that don't really require a medical approach particularly. And the elephant in the room, if you like, is the 70 to 80% of stuff that we see in OH departments and that you will see in return to work interviews and on sickness stats, is instead these chronic health problems, which need to really be treated not through a safety approach and not through a health approach either, but through the more pragmatic kind of approach that Norton Hadler was espoused. So that's a much more human approach to a problem, not being overly preoccupied by the symptoms themselves, but actually applying human, practical, often management skills to a problem of identifying what is going on in someone's life at the problem at that time, with a view to identifying the strategies that would help them to be able to remain in work and to work to their best potential. And that's, I think, quite an empowering message for line managers, because what we're really saying is that often the skills that are really helpful are human skills, management skills, and not necessarily the kind of stuff which external experts are able to contribute a great deal towards. So this is my final slide to bring things to a close in terms of what that means in practical terms for the way OH companies and employers interact in the years to come. And I think what we need to move away from is the approach which is summarised on the left, which is really one which is very predictable, very stereotypical. Someone reports symptoms or health problems, and the mode by which occupational health support is sought is to refer that person. And the predictable response of the OH provider is to arrange an assessment for them, which is automatically beginning then to focus on what the health component might be, and not the broader aspects that we've mentioned. And the reason that's an inefficient approach is you're diverting medical resource, nursing resource, whichever clinicians are involved, towards a large group of people who are going to get better anyway, and who are going to come back to work anyway, and for whom the tools that might help them come back to work sooner are not particularly medical. And the paradox being that actually medicalising them too much can be positively unhelpful. And what we need to move to, in my view, which is summarised on the right, is much more of an orchestral approach. So we need many more strings to our bow. So rather than the assumption being that people necessarily need assessment or they need medical assessment, it may often be that what's going to be helpful is going to be talking to line managers, talking to the people who are involved in constructing the work environment and the morale and the culture of the workplace, for them to understand a little more about what underlies many of these problems, to have a greater appreciation of the limits to which a medical approach can be helpful much of the time, and which is an empowering message for those managers. And of course, not to deny that in a minority of cases, probably 20 to 30% of the time, there absolutely will be a need for a more intensive medical approach to the situation. And of course, that's where there are efficiency gains as well, because you're diverting medical resource, which is costly, to that group of people who really are in need. So I've overrun by a few minutes already, so I won't witter on any more. There are my contact details in case they're of any help to anybody. You're always welcome to get in touch with me. And Catherine, thank you very much.
Thank you, Adrian. Very interesting. I'm going to sort of leap in with the first question, actually, with my occupational hat on. This sounds awfully like what I would call, I suppose, the biopsychosocial model. Does it fit in with that? How does that sort of work?
It absolutely does, and it's maybe a different angle on the same problem. I think the biopsychosocial model in a kind of academic context is great, and it's useful as a means of drawing comparisons with a very medical approach to life. I think it has its drawbacks as well. I mean, the terminology is very off-putting. It is more jargon, and I'm sure that a lot of managers, when these kind of terms are discussed, will begin to switch off because it all sounds very complicated and the kind of thing that an expert would deal with. And of course, that's very counterintuitive, because the whole message of the biopsychosocial approach is that these are very human problems, and I think they should be presented in a human context. So yes, it is a different angle, and I think we're just refining our ways of thinking about these problems, and by thinking more clearly about health, safety, and then also the fact that there's a big gulf in between, which is what we might just call life, life stuff. That's quite an accessible way of thinking about the problem, and helping the manager to understand that actually much of the time they've got far more of a role in helping to prevent or resolve those problems than people with any particular health expertise.
Do we actually think the managers have got the skills to do this, though? I don't think it makes a lot of common sense to me, certainly, but do we actually think that managers feel empowered to be able to deal with some of these things? Because surely, people go to the GP and the GP says, oh, it's this. As a manager, who am I to contradict that?
That's a great question, and I think the sad answer is probably not a lot of the time. Certainly, there are examples of very good management practice, and managers are very happy to engage and confident about engaging with people and finding out more about their situation. But that's, in my experience, that's more the exception than the rule. I don't quite know what the origins of all that have been, but I regret that I think OH may have been part of the problem, in that over time, as we are probably as guilty as other medical specialties of adopting an overly medical approach to problems. And of course, that is quite disempowering to managers over time. And they also struggle in a social context, which is we do medicalise problems incessantly. So you're quite right. In society, people down the pub, spouses, friends, relatives, GPs, will often be reinforcing the idea that this is necessarily a significant medical problem, when in fact it may very much be a life problem, a relationship problem with a manager, whatever. So there is a paradox here, in that I think an important role for occupational health in the future is actually going to be involved in the training of line managers, helping to convey some of the principles that we've spoken about today, helping to reassure them about their role in dealing with many of these problems and their ability to deal with many of these problems, and giving them the confidence to do that. And I think the HSE are adopting a very similar approach here. So we mentioned earlier about the drawback. I think if you look at the consequences of the way we've medicalised stress as a problem, stress risk assessments and so on, so treating it as a hazard in the way that we used to treat noise and vibration as hazards, most people would agree that's been pretty counterproductive. And my sense is that there is a desire to back out of some of that. And you may know that the HSE is currently developing a line manager's toolkit for managers, which is actually very much along the lines that we've spoken about, which is to demystify some of this stuff, to provide reassurance, to take away some of these, these ethereal fears about people working when they have some level of symptoms, and trying to normalise it.
Do we actually feel, or do you know, maybe it's an unfair question, whether GPs are being given information on this? Are they having the same sort of training that maybe the occupational health people are beginning to get, in the fact of dealing with some life issues as life issues rather than medicalising them? In 7 minutes, it's a very difficult thing to do, isn't it?
It is. I think so. I think awareness has definitely improved, probably over the last 10 years, 12 years with the health work and wellbeing agenda. I'm certainly finding that we're getting much more enlightened commentary and feedback from GPs who've really, I think they do appreciate the key messages here about the importance of being in work, the fact that having symptoms rarely means you're not able to work, having symptoms rarely means it's dangerous for you to work. And in fact, most of the time, having symptoms means that you're still better off in work. Being out of work is pretty dangerous in its own right for people. So yes, I think that that is spreading across the treatment specialties. They do face many challenges, as we've already spoken about. So the pressures on GP time now are absolutely immense, and patients bring many expectations with them to consultations as well. So this idea in society that, you know, if you've developed symptoms of any kind, you need to rest, and that being in work is dangerous, and so on and so on. These are unhelpful ideas, but they're still very prevalent. And as you say, when you've got 7 minutes in a consultation, to use some of that time to unpick some of those beliefs is very difficult. But I think I'm reassured that increasingly GPs are signposting people back to their employer, back to an OH provider, where we do have the time and the experience to really get those messages across.
Okay, I think one last sort of comment, or I'm going to put something forward and ask you for your comment. I mean, I'm a great one for action, you know, what to do now. If you're a manager and you have a member of staff who you feel, you know, isn't got a medical problem, but there is an issue, right now, should they just be sitting down, having a conversation with that person? And if they don't feel confident involving HR, is that the most pragmatic way to start moving this forwards?
Absolutely, absolutely. I think you know, the fear of engagement and the fear of making things worse is it's entirely disproportionate to the reality. And of course, we see time and again that the real risk and the real hazard is not to engage, and for people to feel unsupported and uncared for by their employer. And of course, conversations can go on a tack that the manager may not feel confident about, or it may appear that there potentially is a significant medical problem there, in which case it's always fine to default to suggesting that the person might want to see their own doctor if there's any concern that they need medical help. I think being able to signpost to EAPs is brilliant. EAPs serve a fantastic role, and of course EAPs have that very pragmatic approach that I'm really endorsing for many of these common health problems people experience. And the manager doesn't need to be a medical expert. That's really the point. I think many managers are concerned if they get the sense that people are asking them to kind of diagnose or to assess the severity of a problem. It's not like that at all. And I think an important difference in the way that management might engage with occupational health providers in the future is it should be much more of a consultative, collaborative relationship than a transactional one. So this issue of not sure if it's a medical problem, don't really know what to do, send it to OH, who automatically arrange an appointment and then get a report telling me that the person should phase back to work over 2 weeks or whatever it is. That's massively wasteful of resources, you know, and a lot of the time the employer knows they could write the report before they send the referral. And actually having some kind of consultative relationship, one stop short of that, where a case can be discussed beforehand, can be very, very helpful, because much of the time we are able to reassure and say, well, look, this is nothing you've suggested is indicative of anything unusual or strange. You know, this seems to be normal human behaviour in the context of a bereavement or redundancy or whatever it might be. And here are our tips around how you should manage it, you know, be guided by your relevant policies and so on. But absolutely, if X, Y, or Z were to happen, if you had these concerns, then give us a call back. And of course, in that event, we've always got the option then of, you know, reverting to Plan B and taking a more medical approach to the whole situation.
Brilliant. I know I said that I was going to stop there. I've just got one more little question just to ask you, which you may have to deflect. But how do we protect the confidentiality if we go down this new system?
In how do you mean, Catherine? Confidentiality?
I think the person's probably thinking about the employee. How do we you know, if we're going to empower the manager to have conversations about broader issues, I suppose, with the employee, I think they're trying to work out how the confidentiality works, because I think they're so used to good confidentiality with doctors and OH providers. This sort of kind of takes it out of the medical model where perhaps confidentiality isn't so well policed, I suppose.
There's some truth in that, although bear in mind that the nature of the conversations often means that they shouldn't be of a very medical nature. You know, if the manager's under the impression they're making some kind of quasi-medical assessment, That's absolutely not what I'm saying. Actually, the conversations should be very practical. They should be very, sort of goal focused, really, in terms of tell me, I can see you're struggling. Clearly, there are things that are making it difficult for you to work for the time being. Can you tell me a little bit about what's happening at home, what's happening here, what's happening there? What are the things that we can do to try and help you? And they tend not to be very sensitive or difficult discussions. And of course, medical confidence doesn't really arise. And I think my frustration as an OHP these days is often I receive hugely detailed referrals from line managers who really have conducted what I would call, it's well on the way to being a medical assessment. But of course, often what's lacking there is the management assessment of the situation. So some appraisal of the wider context, the relationship with the employee, what's happening, what the barriers to the working are. And that's very frustrating because, of course, it's not going to lead us to the answer. And I take your point about the importance of confidence. I think even if the things that are being discussed aren't medical, they may still be personal and sensitive to the person. And so absolutely an important part of line manager training has got to be around the importance of integrity and trust and forming good relationships with employees who report to them.
Brilliant. Thank you, Adrian. I think before I get kicked out of here, we're going to have to draw the session to a close. So can I just thank you very much for that? And I shall be speaking to you shortly. And I just really want to point all our listeners to our next webinar, which is going to be on the 17th of March. And it's going to be on the ISO 27500, the new human-centered organisational ISO standard, which actually fits in very nicely with what we've been talking about, all being human-centered. So please join us for that. Tom Stewart will be presenting that on the 17th of March. Have a fabulous weekend, and I look forward to seeing you all soon. Goodbye now.